This lecture is cranial nerve. There's not that many slides on cranial nerves, but I make it a big part because I'm going to tie this right in with the test, hopefully you take it right. If you get out there and practicing, I guarantee you from today on, from the day we start talking about cranial nerves until you retire, you're going to need to be familiar with cranial nerves. Those of you who've been out there practicing, doing some things, you know that already. Every class you go to from now on here, cranial nerves is important. It helps you in a lot of areas. And so there's only 40, 50 slides or so on cranial nerves. We get into the small details of cranial nerves, but there's not as many as you think. But out of those, on the exam, I'll probably ask you about 12 different questions on cranial nerves. Because I tell you up front, expectations. What do you need to know about cranial nerves is one of those areas where it's everything. I want you to know I don't know how many there is anymore, but there's like 40 slides where we specifically go over cranial nerves. I want you to know how many T's are on each page, where the periods are. I know, I'm joking but not joking, you know what I mean? I want you to know them that well. And you'll thank me when you're like a senior or junior. You'll be like, man, I'm glad I knew those to begin with. Because as soon as you start the next semester, getting into physical exam, you're not going to have to relearn a lot of those things. So we're going to focus in. And because I say that, I often throw a few more questions about cranial nerves. I'm going to make you study them harder than the rest of the material. I might as well ask you a few more questions, right? Doesn't mean I'm going to try and throw some harder questions in there. I'm just going to weight that test. It's the only place I do that. But I'm going to weight it. We're out of that section. Rather than take 2 or 3, I'll probably take like 12 out of cranial. All right, now let me address the pessimist in the room. The pessimist in the room just thought, does that mean that the other 38 come from all of the rest of the material? Yeah. I don't have another answer than that. Yeah, it does. But y'all always seem to do well, so we'll make it through it. Here we go. Y'all. This morning got a little, what I call AMED nuts, right? People all over the place, like there's so many important things going on. We're going to move this, we're going to move that. And I'm like, no, these are small problems. Small problems. Y'all weren't seeing all. I bet I had 30 texts while we were having the exam. I didn't even look at them. I just set my phone down. The iPad and my neighbors worried about getting together. All right, my opener today was, I know I said we're starting. My opener, real quick, didn't give me much faith. I'm losing some faith in the medical field. Some of y'all know what I mean. You're going to the provider, and you're sitting in a room, not even gone through PA school yet, and you're like, this person knows nothing. Right? Or they don't give a damn. You know, y'all starting to see more providers like that? Or they're relying completely on computers rather than the brain. And all. Anyway, I have a hard time with some of them. And my daughter, who's she's about to graduate from A&M in a month or something. She's biomedical science, so she should know a little more medical stuff. But based on her grades, she was like the third in her class in high school. College woke her up. Y'all know me in college said, holy crap, she didn't do as well as she thought she was going to do. But I'm not trying to play her up, but I'm trying to say she went to this EMT class. And they do it for like 12 hours a day, 2 weeks straight, no break. And she went the first day, and I called her at the end of the day and said, how did it go? And she said, this. She goes, well, I had to correct the instructor once. And I go, whoa, stop. We don't correct the instructor in front of everybody. If you got a question or you think they said something crazy, now in here y'all could do that, hey, you said that backwards. I'm not talking about that. I'm talking about clear correction, like you're wrong. And I know her well enough to know that she's one of those people that she's right, and she knows she's right. Even when sometimes you can prove her wrong, she doesn't want to back off. You know those people? That's my daughter, I'm admitting it. But she said this lady got up in front of him, was discussing the heart, and said that blood enters the heart through the aorta. And she said, I couldn't let it go. That's what she said. I raised her hand like, blood doesn't enter the heart through the aorta. It enters through this. She just said superior vena cava, even though we don't spell. She said superior vena cava. And at that point, I was with her on this, and she goes, the teacher says, no, that's not right. I'm telling you, it enters the aorta. She says, no, it interested, she said, we kind of got interested. It interested in severe vena cava because of this. And the teacher's like, we're saying the same thing. And I said, she really said that? She said, yeah. And I said, oh my goodness, what state of the world are we in? You got somebody teaching EMTs who's telling them the heart gets its blood from the aorta. Y'all didn't find it as funny as I did, because you don't know my daughter. She thinks she's being tactful, but she's telling you back to your face most of the time you're wrong. Didn't go well for her when she was younger. Not with me. But as a parent, even if I'm wrong, I'm right. All right, good stuff. Yeah. Yeah, there you go, right? Section of the brain. The way this is set up, we're going to go through and look at the brain stem. We're going to work our way up to the cerebrum. Then we'll get into the spinal cord and cranial nerves, and then finish out some more autonomic nervous system things. For now, we got to look at the anatomy. When we look at a section of the brain, we have the brain stem. We'll define all these out even more later. But we have the brain stem, and the cerebrum sits on top of that. Right? Cerebrum here, but separating. Sergeant Cole Johnson says she's going to get this pen fixed. We're going to see. I told her again this one. And then you have your cerebellum that's back here. The diencephalon is between the cerebrum and the brainstem. So it'll become apparent as we go through these, but these are the major parts of what we call the brain. Surrounding that and protecting that, you have these hard, sometimes soft coverings called meninges. You have the dura mater, which literally means tough mother. So there's your t-shirt get made for the gym, right? Tough mother. You'll see later you can get corpus callosum. Then you have the arachnoid matter, and then you have the pia mater. So all three of these, if you look at how they're structured, they're going to go from superficial to deep, where we have dura mater, arachnoid matter, and then the pia mater is going to line the cerebrum itself, or the neural tissue. When you look at the meninges, they're going to extend all the way down around the spinal cord. So they're going to cover the cerebrum, and then they're going to cover the spinal cord, and they're continuous. The only difference between them in these areas is the dura mater in the cranial region has some separations. So in certain areas up by our cerebrum, the dura mater splits into two different layers. It has an external periosteal layer that's going to stay attached to the bone, and then it has an internal meningeal layer that's up against the meninges. Basically, we're pulling the dura mater apart a little bit and creating a space in some areas. Right? So everywhere else, the dura mater is fused, except for where some areas it splits. So I'm going to back up and show you that this is one of them, where here's your dura mater. And all of this green that we see here. And this layer, when it splits, we would call this the periosteal layer, external periosteal layer, and then these would be internal meningeal layers because it's up against the rest of the meninges. And so this space that's here is actually called a dural venous sinus. It's a thin-walled vein. What do veins have in them? Venous blood. This is how, when we look at like the external carotid artery, the external carotid artery feeds the blood supply to the outside basically of the head, and then it has to drain away. The way it's going to drain away is it's going to go into these dural sinuses, and that will take the blood away from the brain back to the external jugular. You don't have to write all this down now. I'm not telling you stuff I won't talk about later. But that's what a dural sinus is. It serves one more purpose that we'll talk about later. There are extensions of the dura mater that go between the different hemispheres of the cerebrum and the cerebellum. You have the falx cerebri, as in cerebrum. The falx cerebri separates the two hemispheres. Brain. There was a brain. It's not a great example anyway, because you really can't. But if you take the brain, a lot of it's gone. If you look at this separation, your two cerebral hemispheres are not connected. Well, they're connected. They're not. They're separated largely, though. So there's an extension of dura mater that goes down between here called the falx cerebri, or the separation between the cerebral hemispheres. There's also a falx cerebelli. I didn't grab the cerebellum. You know I'm going to break it. We're going to just hold it together. There we go. That'll work. You have the falx cerebelli, though the cerebellum has two hemispheres also. Right? So there's a separation between them called the falx cerebelli. And then there's a separation that goes between the cerebrum and the cerebellum, and that's called the tentorium cerebelli. So this is a tentorium that's going that way. I have some pictures, if you can't visualize that on this brain, that if we look at a cross section, right, this is our falx cerebri. I'm going to jump down here to this picture, because here's your falx cerebri here, and then there's a tentorium cerebelli that separates them. Now we don't see in either of these pictures the cerebellum real clear, but it sits down below, and it just has a separation between them called the falx cerebelli. The only way you're going to confuse them is to not realize whether we're talking about the cerebri or the cerebelli separation. Why do those matter? Because we're going to get into communication from one cerebral hemisphere to another. And if it's separated by tissue separations, we're going to need a connection to get from one area to the other. So we're going to have to discuss those connections. And that's why we're bringing them up. When we look at the cerebrum, it's using a lot of glucose, a lot of oxygen. I said that last week. I threw out that percentage, 20%. You will never, I don't know if I've said this before, I probably have, I will never ask you a percentage question in here. I don't really like percentages. Is it 20%, 30%? Now, will you, outside of my class going forward, you bet you'll get percentage questions, because that becomes important. But I don't really like to play the percentage game. So I don't ask a lot of what percent. What I like is all or most. Rather than learn something, 90% of this is used by this. How about we just say most of this is used by this? I'm just being generic. So don't learn percentages in here. I mean, it helps you to understand what's happening. So in neurons, if we use 20% of the oxygen and glucose in the brain, that means neurons are constantly synthesizing ATP. So they're using glucose. We don't store glucose in the brain, so we got to get it from the blood. So glucose is going to have to be readily available to the cerebrum. That's why you have the large blood supply that goes to it. If we have a large blood supply going to the brain, though, we can't just have anything. Like a normal capillary system, you put something in the body. If you put an antibiotic in your systemic circulation, it will reach all of your tissues. Well, it's not as, depending on the antibiotic and what it's targeting, you know what I mean, but it can. General antibiotic can reach most tissues. Some reach some tissues better than others. I'm not trying to get into pharmacy. But the brain, we don't want that. Because the brain wants to be the capillaries of the brain want to be very selective. That's where the blood-brain barrier comes in. The blood-brain barrier is going to keep harmful things. Now, we don't think of antibiotics as harmful, but some can be. It would be nice if we could get antibiotics past the blood-brain barrier, because we have meningitis and things like that, where you wouldn't have to go in there and do a spinal tap. And they're developing ways to do that, like bombarding the blood-brain barrier, using an ultrasound, and these little molecules are trying to push things through. We're kind of off track in talking about that, but the reason I brought it up is most things won't go through. It's very selective. If you have an inflammation like meningitis, or you have bacteria, toxins, they can break down the blood-brain barrier and allow things to get in there, and that is not going to be good. An infection is going to spread very quickly if you have like meningitis. The last part I put there is some parts of the brain are not behind the blood-brain barrier. They say lack of blood-brain barrier, but just think of them as not being behind. The pineal gland, the pituitary gland, the hypothalamus, area postrema, that will become readily apparent when you start studying endocrine. Is he doing endocrine next? Is that the next one?
No.
Oh, good. So think about when you go through endocrine, you can relate this to mine and say, well, why did you just mention these? Well, these play a role, especially the hypothalamus. The hypothalamus is the regulator of the endocrine system. It has to know what's going on. If it was behind the blood-brain barrier, it would make it very hard for the hypothalamus to receive signals and chemical messengers of what's going on. So it's not behind that blood-brain barrier. And plus it needs to release hormones directly into the blood off the pituitary and things. So think about that when you go through the endocrine side. Other than that, have fun with endocrine. Endocrine is not one of my favorite subjects. Blood, but it's interesting. This is another picture of the blood-brain barrier, and it's hard for you. I look at this picture and visualize exactly what it is. But picture a capillary. Capillaries in the body, no matter where they're at, are leaky. Things can get in and out of them. You already studied the pressures. Interstitial fluid osmotic pressure, blood hydrostatic pressure. You're going to study those again when you look at the kidney. But those exist in the brain capillaries too, but not as to a great extent. The blood-brain capillaries are not leaky like that, because normal capillaries do not have tight junctions between their cells. But here in the brain capillaries, we have these, they're epithelial cells, except because they're blood vessels, we call them endothelial. Remember that? And the endothelial cells in the blood-brain barrier, they actually call them ependymal cells. So once again, I know we don't like it when they change the words up on us, but ependymal cells are just endothelial cells that are specific to the brain capillaries. And they have very tight junctions between them. So everything that gets into cerebrospinal fluid, or in other words, gets out of the brain capillaries to go into the fluid surrounding the brain, has to go through the ependymal cells. And then surrounding those ependymal cells, we have astrocytes. We learned on the last exam that astrocytes contribute to the formation of blood-brain barrier. They don't do a huge role, but they do create an area where only certain things have to go through here too. But most of it's done by these endothelial cells. So like any other cell in the body, the blood-brain barrier, right, if you take something that's water-soluble, try to get it through a lipid membrane, that's not going to happen. What do ependymal cells have? Just like every other cell, they have a lipid membrane. So we're going to need some type of transporter to use active transport to get it across. We're going to actively transport that glucose constantly across the blood-brain barrier. I already mentioned the antibiotics. Some proteins, if they're very large, won't cross the blood-brain barrier. But if it's lipid-soluble, or it's an exchange of nutrients like oxygen and CO2, those all move easily. Anesthetic agents. How quick do you go out to an anesthesia, right? You're out in a second, right? Count back. I don't know why they say count backwards from 100. I never make it past like 95 or something. I'm out. I don't know about you. I want to know if there's anybody that sat there and like 3, 2, 1. I don't think. Never heard them say it. They're normally out. Some of y'all work Anybody ever seen anybody get past like 90? Like countdown? You have? What's the lowest they ever counted? Oh. But that scares me. Because I don't need more anesthesia. I need the minimum amount. Anesthesia is dangerous. Okay. Sorry that happens to you. You know I got red hair. My hair is auburn. My daughter this weekend, I was eating. My hair is just like yours. What? What did I say? Huh? Oh, no. I was eating down in Port Aransas some seafood with my daughter, and she looks at me. I haven't seen her in a couple of months. She says, "Are you dyeing your hair?" And I said, "Joe, I would never dye my hair. I don't care if it falls out, goes gray." I said, "Only," no, can't say that on the podium. I'm not, I'm about to say only, I don't dye my hair. But what's funny is this lady was cutting my hair like a year ago, and she asked me the same thing. I told you all this already. Ever since I started taking the anti-rejection meds for the kidney stuff, my hair went dark. But I had auburn hair forever. It's weird. Y'all quit looking at me. I wanted to make one last note. Alcohol can cross that blood-brain barrier fairly easily, too. Just in case you needed to know that. All right, CSF. CSF is the interstitial fluid that surrounds the brain. I say it that way. We generally never call CSF interstitial fluid, but it helps us to get an idea of what type of fluid it is. It's full of nutrients and waste products. So we think of cells being surrounded by interstitial fluid. The brain cells, the neurons, are surrounded by CSF, cerebrospinal fluid, which is really just a specialized version, very clean, optimal version of interstitial fluid. Right? Why is it like that? Because of the blood-brain barrier. This is how the neurons and neuroglia are going to get their nutrients and put out their waste products, which also means that we need to discuss in another slide or two that because of that, CSF is made, but it must be exchanged constantly, or it would fill up with waste products. We got to keep that moving. I'll show you. When we look at where it's made, it's going to be choroidal plexus in the ventricles. Choroidal plexus is now the name we have to use for when I just say the capillaries of the brain or the capillaries of the cerebrum. It's actually in groups of them, and the groups of them are called the choroidal plexus. And we find that in the ventricles. The ventricles are like open pockets inside of your neural tissue there. And of course, they'll still be connected by tight junctions, ependymal cells, and then it's going to circulate through those areas. Here's your ventricles. You have 4 of them. We have the lateral ventricles. Doesn't matter to name them, which one's 1 or 2. There's 2 lateral ventricles that sit up here. And then there is a 3rd ventricle. Now we haven't studied the thalamus yet, but the thalamus also sits in this area. And so you have 1/2 of the thalamus on each side of this open ventricle here. And then down here we have the 4th ventricle. So all of these are connected. You're going to see that CSF goes from the lateral ventricles into the 3rd ventricle. And then from the 3rd ventricle, they're going to go through what's called the cerebral aqueduct and make their way to the 4th ventricle. And the 4th ventricle is open to what's called the central canal. Getting a little bit ahead of myself, but in other words, it's going down the center of the spinal cord. So all of these are the things that CSF does. Shock absorbing medium protects, from physical injury, unless you keep just getting hit in the head. You've seen that in boxing, right? Coup, contra coup stuff. But it is going to protect that tissue, even though it's kind of floating, the cerebrum's kind of floating in there. But what we focus on here even more is looking at, it is the chemical composition has to be maintained with the exact amount of correct ions that allow what they call optimal neuron or optimal ion concentration for neuron signaling. Because we know that neuron signaling is moving ions. So CSF is a very good environment for that. And of course, we're going to exchange waste products back from the blood to the nervous tissue or nutrients. So if we look at CSF, the way they normally talk about it is you're going to have CSF that is formed in each of the two lateral ventricles. Like I said, this is talking to what I got in the picture. Then it's going to go into the third ventricle. There's nothing named, there's no named connection between the lateral ventricles and the third ventricle you need to know. But from the third ventricle to the fourth ventricle, you have that central, you have that cerebral aqueduct that connects it to the fourth ventricle, then onto the central canal of the spinal cord. All of the ventricles have a choroid plexus that makes CSF. So while most of it's made in the two lateral ventricles, the third ventricle makes a little more, the fourth ventricle makes a little more. You're constantly producing cerebrospinal fluid. I put this on here just to show you, these are the lateral ventricles. If you were to take a transverse plane of the cerebrum, you would see these openings. And down in them, over here, you'd see there are choroidal plexus. If you were to blow the choroidal plexus up, which is just a clump of capillaries, we would see that if you looked at one little capillary, it would be lined with ependymal cells. Sorry, I drew the other side of it. And then they would project out. So anything that's going from the blood to or into the CSF, cerebrospinal fluid, it's got to go through those ependymal cells. Okay? So we're constantly making this. We're constantly making CSF. CSF then is going to need to be reabsorbed. Where this is going to happen is in a special area called arachnoid villi. I have to mention that cerebrospinal fluid, we keep talking about it flowing around, but cerebrospinal fluid specifically flows around two of the meningeal layers. It's in the subarachnoid layer. Right? So you ever heard of subarachnoid hemorrhages and stuff? But that area has your CSF that it circulates through. So if we look at the red area, this is the arachnoid matter. And this is the pia matter. So in a second, we're going to look at the spaces between these. But I needed to say this before I talked about this slide a little more. Is here in red with the little crosshatches, that's the subarachnoid space. The subarachnoid space is where cerebrospinal fluid flows. After it comes out of the ventricles, it goes down through the central canal of the spinal cord and comes back up around the subarachnoid space. The reason I had to say that here is when you look at reabsorbing CSF, that's going to occur at the arachnoid villi. So you remember those dural venous sinuses? You find here, what's a dural venous sinus? Is a thin-walled vein. So a dural venous sinus contains venous blood. Did that for a reason. I don't often talk that way. Okay, well, arachnoid villi project out of the subarachnoid space, and they project into the dural sinus. So the way that cerebrospinal fluid is going to be reabsorbed is to flow through all of this subarachnoid space, and then at some point it's going to come into the arachnoid villi, and it will be filtered back into, they call that reabsorption of CSF, but it will go back into the dural venous sinus. So then I ask again, when you question what's in a dural, what fluid is in a dural venous sinus? Venous blood. The reason I'm saying that is I've asked people before, and I asked them what's in a dural venous sinus, and CSF was one of the answers, and they answered CSF, and I'm like, well, how would CSF get in there? We're filtering things back out, but we wouldn't call. I'm waiting for somebody to argue with me and go, is there the dural venous sinus contains A, B, C, D. A is venous blood, B is cerebrospinal fluid. And people would answer before cerebrospinal fluid. I'm like, well, no, there's not. You're like, well, you said it was reabsorbed in there. And I'm like, name me another area of the body where something's reabsorbed and you start calling it that inside the vein. Does that make sense? You're reabsorbing the waste products and all that. So the waste and other things that you don't need are getting reabsorbed and some of the fluid. But we're technical in anatomy, right? The venous sinus is still just venous blood. We're reabsorbing it into it. Am I making sense? I wouldn't want y'all to make that mistake if I decided to ask you again.
Sir, so the superior sagittal sinus is the dural venous sinus.
Yes.
It's a different name for it.
Yes, and thank you, because I didn't mention that before, is there are more than just one. There are dural sinuses that we could name. This one just happens to be sagittal. So that one's named the superior sagittal sinus, which means we have an inferior sagittal sinus. I'm just not burdening you down with naming all of them. But there are many. They're not just one or two. There are several. But all of them just drain venous blood away from the head. Okay. So if I ask you that, that's 100%. I don't know if I do. I'm tired of people getting that one different. Y'all are all looking at me like I'm crazy. Now you got it so much that you're wondering why I'm still talking about it. Okay, hydrocephalus. What happens if cerebrospinal fluid is made too fast? I didn't give you the time frames. I may have said it on a slide, and I'm not real concerned about it. But about every 90 minutes or so, the CSF is recycled. It's completely exchanged out, which is no different than other capillary systems. If you make too much, it can't drain out fast enough. That's hydrocephalus. You have excess CSF fluid accumulating in the ventricles. If you're an adult, you have no soft spots. Right? You shouldn't. You have a hard cranial skull. And so since all the bones in your head have fused and your cerebrum sits inside of here, and if the ventricles are in the middle of your cerebrum and they start to fill up with fluid, what's between the ventricles and the hard bone of your skull? Neurons. And those ventricles will continue to swell. Your head won't swell because you're enclosed. So it's going to compress your neural tissue and kill it off. You're going to die. Right? That's no other way to put it. That's why when you hear about people getting like subarachnoid hemorrhage, because CSF can do that. In an adult, that can happen in an adult. The blockage can occur. I'll talk about that in a second. But even blood, if you put blood into that area, it will expand too. Right? And it has nowhere to go. But in babies, they have fontanelles. Right? Fontanelles are just where the sutures haven't closed yet. So if you're, I think of some show I was watching not long ago where the guy had an intracranial bleed in like before modern medicine, and they were like drilled into his head with. Anybody know what show I'm talking about? I can't even remember. They took one of those old drills that you do this, and they drilled into his head.
Yellowstone.
In 1923, that's right. It was one of the yellow. And then he gets up and runs around like 10 minutes later. Did you notice that? He was just fine. Drill into his skull. But that's what it takes. We got to get that stuff out of there if you're an adult. It's not the only way you'll learn in emergency medicine. I'm not getting into that. So I don't recommend just walking into emergency medicine and saying, oh yeah, if you have intracranial pressure, I'm going to just drill a hole. No, there's some other things we can do. We can go back to our eye blue fluid talk in a second. No, I'm not going to do that. Okay, so what happens if you have CSF overproduction? You get hydrocephalus. Okay. I'm going to jump to this and I'll jump back. Here's hydrocephalus. On the left would be normal, and then you have this baby that has these enlarged ventricles. So in that case, the cause of that is overproduction of cerebrospinal fluid. And what they can do is go in there and put a shunt in. And they're going to take and shunt the blood from the ventricles to another area of the body that can reabsorb it. So where else can we reabsorb it? They either do a shunt to the right atrium, or they'll do a shunt to the peritoneal cavity. Because your peritoneal cavity is highly vascular. But you can, nowadays you can do, you've heard of dialysis, changing out your blood with a dialysis machine. Now they also have peritoneal dialysis, where basically they leave a catheter in the patient, and then they hook up to a machine like once or twice a day, and they have these big bags of fluid, and the machine runs that fluid into the peritoneal cavity, then they disconnect it and they walk around with that all day, or they sleep with it. Depends on, varies. A lot of them sleep, and then when they wake up, they pull that fluid back out and they go on with their day. The fluid's very osmotic, just like down at our kidney. It functions like your kidney does.
Pulls it out.
It pulls out the waste products. It's kind of interesting. But you think, oh, they put a little fluid in there. No, I'm talking like a liter or more. Big bags of fluid. And so they'll drain that into them. And then you can disconnect from a catheter. The patient can go walking around, do their normal day, then they come back. The catheter is just left in place. Kind of interesting. I'm getting way off topic of medical stuff we don't need. Right? Once we get to block 6 and 7, y'all are going to give me dirty looks when I do that. I know how it goes. No, I shouldn't say that. Y'all aren't the average class. Y'all are going to want to learn the whole time. Hey, what about an adult who develops hydrocephalus? Not a bleed, but hydrocephalus. I don't know a whole lot about this, and I have read about it. It's not real interesting because there's no set things, but here's what I do know. Some patients get obstructive hydrocephalus, which means basically the CSF that's going through the ventricles gets blocked. And I was reading about it going, because it's called a third ventriculostomy. And maybe somebody in here has seen it before I haven't. They go in and make a hole in the floor of the third ventricle, and that allows it to bypass the obstruction. Which the side I got kind of rabbit hole on is like, well, couldn't an obstruction be other places? Is there only a third ventriculostomy? Yeah. That's how you treat obstructive. But most of the time, if you see hydrocephalus at all, it's not going to be an adult with obstruction. It's going to be a child. And most likely, you're going to be deployed at the time. Because they catch this fairly early in kids. You ever gone in to see a newborn that has a tube coming out of the top of their head? That's a temporary shunt until they can go back in and place a permanent one. If you look in this kid's neck on the right, he has a shunt that's going down. See that thing? And as they grow, that sometimes will be replaced. Because whatever's causing them to make too much CSF, it's not going to change. Some of y'all probably may know some people that have had a shunt for this. So they'll either do a shunt to the heart or a shunt to the abdomen. Kind of crazy looking, huh? Your head can swell that big. Now picture that much swelling, but compress it back down inside of a skull, and imagine what that would do to somebody's neural tissue. Yeah. We could go off track. I could go way off into interesting stuff about like brain bleeds and actually I will, and then we'll take a break because y'all need it. On the way to phase 2, my father-in-law and my mother-in-law decided they were going to travel with us, and we were traveling, pulling like a pop-up camper because I didn't have any money back then. They had a big Class A. Yeah, but we're traveling. That was supposed to be funny. I was one of the pop-up cameras got broke. Anyway, we're traveling out there, and we're all together, and we stop in Georgia, and I'm trying to shorten the story. My mother-in-law and father, she'd always had like headaches. She took stuff for migraines and things. And a year prior, she'd been in an accident over in Conroe, Texas, where she was going down the access road, and a diesel came like out of nowhere and hit her in the side of this little S10 Blazer or whatever, and split it in half and threw her out onto the pavement, sliding head first. And she lived through all of that in the surgery. So we're a year later from that. Nobody's thinking about this. And she comes up and asks me, "Hey, I'm having this headache, but it's like, you know, I can't get rid of it. I know I can." And the question she asked me as a phase 1 graduate was, "You think it's okay to take some of Hal's nitro?" And I said, "No. I don't even know what's going on." I said, "But you should." I was too regimented. You shouldn't take anybody else's meds, you know. I said, "But nitro?" You know, he has heart problems. And I said, "No, I don't think that'd be okay at all." You know? And so she went on and took her whatever meds she takes for migraines. But her head was just really hurting. But at the time she asked me that, she's out walking my, 6-month-old son around in a stroller. That's not somebody acutely ill, right? Not 3 hours later, like at midnight, my father-in-law, them are calling me over there. He's calling an ambulance, and she's over there unresponsive in the bed. And this turns a little sad here, but it's a good learning moment. And so they take her in. She actually had a leak that formed from the prior accident, and she had a subarachnoid hemorrhage and was hemorrhaging in her brain. But by the time they got her to the hospital, it was completely full of blood, and whatever. She didn't make it. But it went from walking a kid in a stroller to 5 hours later, just dead because of that. And so you always have to be aware of what your patient is doing. Now, did she ever take a nitro with my father-in-law's? I hope not. I don't know.
Would that have helped?
What's that?
Would nitro have helped?
No, I think it would have made it 100 times worse.
Yeah. Good.
It would have dilated and everything else. She would have just bled more. Anyway, that was the only time I've ever really, other than being deployed or something, but to see that and to see, because the whole reason I told the story is not to say, oh, I missed something, or this is cool, or it's a sad story, is that when you look at a patient sometimes, they may look completely normal. There was no reason. Like, what do you do about that? I got a headache. The only thing I can say that she did say is, you're going to learn. If somebody says, I have headaches all the time, or I've never had a headache, if somebody says I have headaches, like I get headaches every now and then, my wife doesn't, okay, there's a difference. If somebody says, I have a headache, but this is the worst headache of my life, ding, 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 right? That's going to be temporal arteritis or something. They're in trouble. They say those words. That's going to be specific for the patient. If somebody says, I have the worst headache I've ever had in my life, they need to be seen right away. Which sounds crazy, right? Because what do you wait? How many of y'all woke up Memorial Day weekend one of those days going, I've never had a headache this bad? You probably have. You just feel like that morning. Anyway, we're getting way too medical stuff, but that's a key. But the only time you'll probably ever hear, I have a terrible headache or the worst headache, generally as a PA for me, the headache comes in at 4 o'clock on a Friday, 3:55, last patient, there for a toenail, hangnail in their toenail or something, and I'm like, and before they walk out the door, they're like, I need to ask, I'm like having this headache. I've never had a headache like this. You're going to learn. I hate working up headaches, because what causes it? A million things. You got to figure it out before they leave. Let's take a break.
Now I'm just freaking out about my head. Maybe he's just compensating for the last 2 weeks, That smack really had us.
Yeah. They did reset it. Here's the.
They were scared to talk to me. Somebody's scared. Does not contain CSS. There will be a sign, does not contain. By definition.
That's what going on. I'm comparing it to another illustration. So technically, it's the villa inside. And part of that, the part of the villa has CSS.
That's part of your actual not the science itself.
But it is practically part of like a combination of two to create.
It's an extension of the subarachnoid space into that area of the section, into the science.
I just consider them two separate entities and not like.
Another example would be like in a kidney, say, where the glomerulus blood. But when you get into the capsule, there's something called a fluid in the capsule.
But inside the Bowman's capsule, where it is in there, we're just talking about the filtration unit as a whole. Like that, the way my brain works, like part where it's coming in is, you know what I mean? So like, to me, it's like my brain is doing combined and then one entity. So treating as two separate.
Or thinking of it more looking at Somebody O'Brien never need to know here. Except in here.
I don't want to say it just in case
That's my biggest. Yeah, I was literally thinking that. I was like, when I saw it, it's right here. Just reference you showed me.
That's a nice ragdoll. That's a nice ragdoll. You'll learn from that. I'll learn from it. My wife bought me a new creeper under the car, but it doesn't have holes on the side like holes in it. And when I roll around, sometimes I'm pushing my elbows underneath the car, my feet are moving, and it got caught in the wheel caster 3 different times. I was screaming like a little. That hurt like all get out. And I was tightening U joints at the time, so you're already ticked off.
Yeah.
It's hard enough under there. But I kept back putting lift blocks back there. I was already irritated, and I kept doing it. And I wouldn't learn, and I'd do it again, and I'd do it again.
We do, not one, so 1 and 3. No, today's schedule is, yeah, we made, the A&P 2 lecture got moved to our own Yeah, I've been this for
Yeah, no.
feel like they.
Yeah.
I have like every 2 years.
Yeah, I guess they grow.
Maybe I should.
My average goes down. Like I have like say now.
There is a for that road where that one by.
Oh yeah.
Buy one of these too.
My wife and daughter made like a play or whatever. That has a stand. Not just what if her drawing is? She uses like it's not gonna stay for something. Just fold over. She makes me a drawing every day.
This weekend, I made this. They don't ever make it out here. That's true. I can put it on my website. Yeah. I chose to make some of these. I like to try to you see like them like by like a picture frame now, where like all your kids are cut. Put a picture frame, like put the next one in front of it. It's always like a changing picture, or whatever. And I'm like, it's really cute. It's not like it's bad. It's just
All right, ready? Ready?
He's creative, so it's great. Keep going, but it's not saving every time you put pen to paper. Not every day. Every day.
What they painted you do? It's almost like a painting. It's better than a real man. That quiet. That's cool. When they said they were going to send people home, I'm the opposite. This is why I don't get along. People don't always like my opinion. But my first answer was, what do you mean? They just I don't care how hot it is over there. They take the tops off and we suffer through it. Well, y'all are suffering through it.
Oh, it's so hot.
Throw some fans in the doors. I guarantee you, it's because somebody decided that they were too cold when they told somebody. You don't ever tell people you're cold around here. But I do know this. You can expect this room to be hot tomorrow. It's,
Think about it.
I know. They have so many different, like, this room will be connected to a room on the, I don't know what's going on up above this ceiling, but they have these weird zones for AC. If you ever looked at AC zones, and you would think like this room and that one, or the zone, it's not like that at all. It'd be like this room and somebody down in the basement are on the same zone. Like, what? And they'll say it's too cold, and all of a sudden you're hot. But I know this, anytime that side starts complaining about it's too hot and it's cool over here, the next thing that happens is it's hot over here. We'll see how tomorrow goes.
In the winter, is it super hot? Or is it?
It gets pretty warm. And they don't always, it's Texas, but they follow everybody else's set. You know, there's a set day to turn the heat and cold off. And so they only do it on certain times. And so a lot of times we'll come in here and it'll just be blasting heat. That's why I say in the winter I would keep a pair of PTs back there for the whole class. So if one person has them, military ain't letting that happen, right? Everybody has them. Class leader might be able to say, hey, can we go to PT? The question is always, is everybody going to look the same? And then that's where the Air Force comes in, and we start having more problems. So. It's good. Good. Easy target. Somebody asked, what's that? What's funny is if you crack about, like the Air Force have cushion tracks to run on and stuff, if you crack on that, most Air Force people I've ever known won't go, yeah, screw you. They'll go, yeah, you just don't. They do. And you know what I am. I didn't realize it until I went to MacDill Air Force Base for Phase 2. He asked me where I went. They do let Army go to Air Force sites and stuff occasionally. And I went out to run. I was running. They had this nice track along the beach. And it's cushioned. Back then, there wasn't as many cushioned tracks around. And I'd always been running on the road with the Army. But I was running, and I started to notice every now and then, though, the track stops because you got to cross a road. And I would notice, like, more and more I ran, like, when I would hit that, I would dread hitting the pavement. And I went, so for the last 12 years, the Army's been running me on this hard pavement. I didn't notice it until I got on the Air Force soft track. And I hit it, my knees would hurt for like 20 feet, and then they'd feel good again. I joined the wrong service. MacDill's an interesting, anybody ever been stationed in MacDill? You got like lieutenant colonels that are drivers there. That's all they do. They're like some general's driver. Then you got a bunch of snowbirds that come and get pulled over for drinking because all the retired people go down there and stay on the base for the winter. And you'll see them at the Class 6 with carts full of liquor when they get there. I mean, it's just pile. It looks like they're grocery shopping, but they're not buying any food. I love those people. Back then, I aspired to be them. Not so much now. Okay, here we go. Medulla oblongata, the pons, and midbrain. In other words, we're going to look at the parts of the brainstem. Right? And if you look at the picture to the right there, that's how it's divided. To where up here we'll see we have our midbrain, and then you have the pons, and the medulla oblongata. So we're going to look at them individually, and it's color-coded here to show you the portion that is the medulla oblongata. So that means your magnum foramen, the opening in the base of your skull, that hole, where this would be your spinal cord. As your spinal cord connects to the brainstem, specifically to the medulla oblongata portion. In other words, we need a way, this is an overview before I talk, we need a way for all of the information going out to like our extremities and the rest of our body to go to and up the central nervous system. Things are going to come into the spinal cord, which is part of the central nervous system. But once it gets in there for sensory, it has to travel up to the cerebrum, cerebellum, other areas. And then it has to go back down and out. So the brainstem is a connection between the spinal cord and the cerebrum. But the brainstem, we'll see, has a lot of specific functions because you can be alive without your cerebrum. Your cerebrum is your executive suite. Your cerebrum is where you make conscious decisions and where you have perception. We're going to get deep into this later, but you know, there's a difference between saying sensation in the body and perception. So, kind of, I shouldn't be getting ahead. Do you have sensations in the body that you're not aware of? Yes. Does anybody right now tell me their blood pressure? No. I mean, you can think my blood pressure is high. You don't know that, right? Does your body know what your blood pressure is? Yes. Because your brainstem functions and it's receiving sensory. But the only way we have perception is if it reaches the cerebral cortex. So we have like sensory for hot that has reflexes and things are hot and it tells the cerebellum. So but we're not consciously aware of what happened until it reaches the cortex. I'll get into more of that later. But this is, the whole point was this is the connection for all of that info. So the medulla oblongata is called the vital brain because it controls a lot of what we say keeps us alive. Now, you need this area. You must. These are involuntary areas. In other words, the brainstem is full of nucleus. Nucleus is a collection of neuronal cell bodies in the central nervous system. So there are collections of neurons, cell bodies, in the medulla oblongata. But we're going to say, not only that, we're going to name them and say, okay, what does this collection do? You may have already talked about this in cardio when you talk about heart rhythm, contractility, that kind of stuff, where it's regulated. We're going to look at the rest of them because breathing, heart rate, blood pressure, coughing, hiccuping, swallowing, vomiting, all of these are controlled by centers. Now I'm using centers, but what do I mean by that is the nucleus. Nucleus centers for these actions are found in the medulla oblongata. I got ahead of this, but once again, the magnum foramen, I mean, if you don't really know what that is, that's the base of the skull. There's an opening, and at that point, the medulla oblongata starts. Your brainstem is not really as long as you think it is. It's a short kind of area, but we're blowing it up here on the screen. So it's going to contain sensory and motor tracts. If you think of your cerebrum being up here, and I just said we got to get that info to it, we're going to have sensory that's coming up through the medulla oblongata. And we're going to have motor that's coming back down, ascending and descending, afferent and efferent. Different words meaning the same type of thing. This box, though, all of these are all of the areas of the brainstem have to have sensory and motor both going up and down. And why is that? Because we're reaching the cerebrum or higher areas. And so we're going to break it down and we're going to say, well, there's the medulla, there's the pons, there's the midbrain, but all of those tracts have to go through all of them to get to the cerebrum, right? So that's not going to be anything different with each area. There are some specific white matter tracts that we find on the anterior side of the medulla oblongata, and that's called the pyramids. So these are pyramids. These are just large white matter tracts. Just means they're myelinated. And then you have a connection between them. That's called, instead of saying crossing over, when you talk about neural information going from one side to the next, like right side of the brain controls the left side of the body, that kind of stuff, they call it decussation. So they decussate. So one of the big areas that things decussate is at the medulla. So when we look at things like hearing, we're going to see that as you take that info into your ear and it goes to the medulla, some of it will cross over, some of it will stay on the same side before it goes to a higher center. But this is just one big area where things can cross. Or when it's going down, it doesn't have to be sensory. So what you want to pay attention to as you go forward and studying for like exam stuff is what nuclei are found where. Like what nuclei as we go through this are in the medulla and what does it do, and what are in the pons versus medulla. That's what we're going to focus in on. So you have the cardiovascular center that regulates the force of the heartbeat, it regulates your blood vessel diameters. You have the medullary rhythmicity area, which is part of the respiratory center. So there's a respiratory center that's named that consists of nuclei that are in the medulla and the pons. So we're only looking at the part of it that's in the pons and in the medulla. And in the medulla, that's the rhythm area. Breathe in, breathe out. Breathe in, that's controlled by those nuclei. The deglutition center is what promotes swallowing. Deglutition means to swallow. And then the gustatory nucleus, gustatory means taste. Like a taste bud is actually called a gustatory receptor. gustatory center. You get input from taste buds of the tongue. There's a lot of these. The medulla is the main one that's busy. You have cochlear and vestibular nuclei. Right? There's some overlap here with the pons on these also that we'll see. The cochlear nuclei receive auditory input. Cochlear is associated with hearing. Vestibular, always associate vestibular with equilibrium. So in the inner ear, we have cochlear ducts, then we have the semicircular ducts, things that pick up hearing, things that pick up equilibrium. And they're going to be transmitting their info back to here. And in the vomiting center, the area postrema, we saw that word earlier. The area postrema is not behind the blood-brain barrier, and it's the area that's responsible for vomiting. So in my mind, I picture, you drink that goat's lager or whatever you like to drink, you slam it and it comes right back up. Kind of facetious because the area postrema senses toxins in the blood and makes you want to throw up to get rid of whatever you've eaten or drank. Though when I said that analogy, I was thinking of my buddy who watched him years and years ago, this is a long time ago, Fort Riley. And he slammed that ghost lager and it went, that's what you call it, right? I don't drink that stuff. Yeah. What's that? Yeah. And it went in, and it's almost like you could see it like a cartoon. It traveled to the stomach and came straight back out. And I'm like, that was awesome. Those are, I don't really drink that much hardly ever anymore. So back then I did. And so I'd had enough to drink it. I thought that was awesome. I never let him forget that. Neither will the bartender. He's all over. He's an idiot. Okay, everybody's somebody else's idiot. Other nuclei we won't go as much into. We understand what coughing, hiccuping, sneezing is. We're going to focus on one other area that's found here. On the lateral, right and left sides of the pyramids, you have these areas that are shaped oval-like, and they're called the olives. Right? Olive, you can call it whatever you want. It's an area that relays impulses to the cerebellum from the cerebral cortex. Other areas like red nucleus of the midbrain, spinal cord proprioceptors. As we go through these, I'll focus you in on some. But when you study neuro, you want to study where it's going from and where it's going to. Always. Whether that's a simple thing like is this an ascending sensory tract, or whether that's saying where does that control come from, or where is the reflex for vomiting? Well, it's in the area postrema of the medulla, which is a collection of neuronal cells. You see where I'm getting to? As y'all study this for my test, I want you to pay attention to that. And if you get confused about whether it's important on something, ask me. I will. But this area, if you were to define them, basically you're relaying impulses from areas like or to the areas like cerebellum, red nucleus in the midbrain, and we're going to figure out what all those are. We'll get back to that even more. The next section is pons. If you're just looking at a diagram like this picture and you're trying to figure out the pons, it's not normally color-coded. We would come in here and actually draw this as a hard to find. Disappearing. When I put it over the picture, I can't see it. Anyway, I was trying to say it looks like now it's doing the same thing on the other screen. You know, maybe I got to go back to this one and draw it. And now this one's working just awesome. I guess Cole Johnson fixed something. I don't know. Kind of looks like a D, but I call it a P for the pons. I was trying to draw just out here, so you can see it kind of looks like a P. I know that sounds like rudimentary anatomy or whatever, but sometimes you need that little memory visual, right? Instead of calling that, so you don't call that the medulla oblongata area. The pons is the next area as we go up the brainstem. We moved out of the medulla oblongata to the pons. The pons is kind of like a bridge that connects one part of the brain with the other. Specifically, what it's really connecting is if you look at where the cerebellum sits behind, back here, the pons are tracts that connect both sides of the cerebellum. And then you're going to have other areas of the pons, just like we saw in the medulla, they go up and down. So these are going to connect to the posterior side where the cerebellum is once you get around on the back side. So you would have tracts that go to one side of the brain or the other and still have ascending and descending tracts. And all of that is said on the next slide where you say you have bundles of axons in the pons, and the pons either laterally connects the left and right side of the cerebellum, or there are vertical tracts for ascending and descending sensory and motor. So a large part of what the pons does is to take voluntary movements from the cerebral cortex and send them to the cerebellum. In other words, to coordinate movement. The cerebellum is associated with movement or refining those movements, and it does that in real time. So as you go to start, kicking that soccer ball, if you're one of those crazy people that like soccer, nobody took offense. Come on, you got to banter back sometimes. I know there's a soccer fan in here. Actually, it's not. They're not acknowledging. When I don't get any reply to that, they're not acknowledging because I'm not calling it football. Anyway. We didn't have soccer when I grew up in school. We had big rubber kickball that in elementary school they'd throw you out onto the playground and say, "See you in an hour." And I never called it soccer. I didn't really. Texas didn't have a whole lot of soccer back then. Now they do. I don't care. I don't really care if you like soccer or not. It's fine. I just don't watch it. It's like tennis to me. Because every time they get it, see, I'm digging my own hole. I keep doing it. I learned to appreciate soccer because the guy I worked with showed me his daughter's bruises and stuff after college soccer games. And they're brutal. So I learned to respect it more then. But I never really watched it, so I'm just being funny. And it's not funny to the football people, the soccer. But I didn't like it. I put my kids in it when they were young, because I made them play all sports up until 10th grade. So even in their first year of high school, they had to play every sport that they could get on. And Bernie, that was, if you're any type of athlete, you can get on to basketball, volleyball, that kind of stuff. And then you can choose to focus on one. Anyway, because you're not going to be doing that for a living. But I put them in soccer. And they weren't in there very long, because the only teams that win in 5 to 8-year-old soccer, they teach one person to stay back, and his whole job, or her whole job, is that if anybody gets away, is to kick it out of bounds. What kind of game is that? You kick it out of bounds. Y'all don't know what I'm talking about? They ever seen those coaches do that? That's when you let them play, though. If you're good enough to come out of that big pack of kids that converges on the ball, and you're having a breakaway with it, I'm like, it's 1-on-1. It should be a goal to kick out. Yeah. That's why I didn't like it. I don't know why I said all that, damn it. Don't stop listening to me for the rest of the semester if you're a big soccer fan. I'm happy that you like soccer. I'm not going to watch tennis either. Let's just be fair. All right, y'all aren't playing with me, so pontoon nuclei. I'm going to help you regulate kicking that soccer ball. Remember, we said in the medulla oblongata we had a rhythmicity center. Hard for an East Texas person to say that. And then in the pons, we have another part of what's called the respiratory center. The pons has the apneistic and pneumotaxic areas. These are pons nuclei that help with the respiratory center as a whole. So if we look at them together, so the action of all your respiratory muscles is controlled by these areas. And so when we divide them up, if we say, well, here's the medulla is below this, So in the medulla, we have the medullary rhythmicity center, and that has an inspiratory and an expiratory area. Breathe in, breathe out. That's the function of the medulla. Breathe in, breathe out. And then the other part of the respiratory center is found in the pons, where you have the pneumotaxic and the apneistic area. So they're going to help you to not breathe in too much or breathe in. That's exactly what they're doing. So when we look at the pons, right? The pons is working the difference between breathing in and breathing out. So the pneumotaxic area will turn off the inspiratory area before the lungs become too full. If you have an apneistic area, that prolonged, like you don't have enough oxygen, it's going to prolong inhalation by sending signals to the inspiratory area to tell it to continue to take in air, basically. So both of these areas, both of the nuclei in the pons, if you didn't notice, have effects on the inspiratory area of the medulla. Tracking? That's the basics here. So an interesting fact when we get to cranial nerves, if you look at the vestibular cochlear nerve, cranial nerve 8, it actually has nuclei in two different parts. So the vestibular nuclei, or the vestibular branch, connects to the vestibular nuclei in the pons. So equilibrium goes to the pons. That's what vestibular is associated with. The cochlear branch of vestibular cochlear nerve, cranial nerve 8, goes to the medulla oblongata. So the nuclei for hearing are found in the medulla oblongata. But you have motor branches that go back. We haven't discussed a whole lot of that yet, but generally, in most areas of the body, not all, if you have sensory coming from an area, you have motor going back. Right? Whether that's, when you start talking about involuntary things, a lot of times that's dealing with setting the sensitivity of receptors in things. But the motor neurons all come off of the pons and go back to the inner ear. I put semicircular canals and spiral organ. It's not real important yet. That would be special senses. Right? Motor neurons will come out of the pons. And the last part of the brainstem is called the midbrain. The midbrain, when it was developing, we have areas in the brain that are called mesencephalon, diencephalon. So the midbrain's real name is the mesencephalon, though I generally refer to it as the midbrain. This is going to connect the pons, so that last part of the brainstem, to the diencephalon. And the diencephalon is where we're going to find things that you've already discussed, and you're about to discuss a whole lot more. The thalamus, hypothalamus, that kind of stuff. And then, of course, it has tracts. All of these areas will always have tracts, the nascent and descent. So there are two areas on the anterior side of the midbrain, and they're called the cerebral peduncles. I love that word, peduncles. Just sounds good. So the cerebral peduncles have sensory. Let me say this the way that's easier to remember. All of the brainstem had sensory and motor going up and down, right? So we got to get to the cerebrum and higher areas. Well, so does the midbrain, right? And so does the diencephalon above it. Well, that's a little different. We'll see that. So all this is saying is the cerebral peduncles contain these sensory and motor neurons that are going up and down. They just gave them a different name. And we haven't discussed it yet, but what do you think this is? You're studying it with Ruggiero, probably. I can draw a little punching bag on the end of it. Yeah, that's the stalk, and that's the pituitary. So if you can see that, you know I'm giving you a way to orientate pictures. Actually, the easiest way I found to orientate a picture of the anterior or posterior side of the brainstem is to look for the mammillary bodies. If there are two rounded projections I know we haven't discussed them, but if there are two rounded projections, those are mammillary bodies. On the posterior side, you're going to see there's 4 rounded projections. That's it, and I'll show you that in just a second. That's the way you can orientate between anterior and posterior. Or you can look for the large pyramid tracks. Or you could just look for the pons, the bridge. I'm saying all that because I know it's easy when I look at the picture, but y'all don't know when you're first learning it, you don't pick those things out. But it's always very important when you look at these to orientate the picture first. So on the posterior, the whole reason I brought that up is when you spin this around and you look at the posterior side of the midbrain or the brainstem there, you'll see there are 4 rounded projections. 1, 2, 3. That area collectively is called the tectum or the corpora quadrigeminum. You don't have to remember those names. I'm going to show you what the nuclei are there. I don't really care. The tectum, corpora quadrigeminum, meaning 4 elevations. Another area here is we find those here. So if we remember back to earlier, we had a 3rd ventricle up here. And it was connected by the cerebral aqueduct to the 4th ventricle, which is here. So that's the cerebral aqueduct going between the 2 parts of the midbrain. So the corpora quadrigemina are on the posterior side of that. That's where we find them. And that's where you see on that picture on the right, where now we can see them. What I would rather you focus in on, instead of using the name tectum and corpora quadrigemina, is just say those are the superior and inferior caliculi. Okay? Because that's what we're going to look at and what they actually do. That's why that's what I boxed. You notice I didn't box anything. Well, I did box. It says tectum, but remember superior and inferior caliculi. These are important areas. The superior caliculi are reflex centers for visual reflexes, like physically tracking objects. So if you have something move out of the corner of your eye, as we say, and it's moving very fast, or it just moves, and you turn your head towards that, or your eyes really, but your head turns with your eyes. And so you look at what's going by, that ghost that just went past you in the hallway, right? You look over there. That's a visual reflex. Something got picked up in your peripheral vision and turned your eyes and therefore your head towards it. That reflex occurs in the superior caliculi. It also will help at the time adjust the size of the pupil and the shape of the lens. Why would it want to control it? I talk a lot about saber-toothed tiger in neuro. Because if you picture you're wearing caveman clothes, cave woman clothes, cave person clothes, whatever you decide to be clothes. Now, and you see a saber-toothed tiger jumps out of your peripheral vision. Hopefully your peripheral vision is good enough that reflex is going to be picked up out of the corner of your eye, and you're going to turn your eye towards that. And it would greatly help if your pupil adjusted the size, because when we get into special senses, we're going to see that allows us to have more acute vision to see what we're dealing with, and we need the accommodation reflex, because that controls how far you see things close up, really close up stuff. And we want it to relax so we can see what's coming at us. So all of that occurs based on this reflex. If you drop down to the lower inferior ones, those are called the inferior caliculi, and they are part of the auditory pathway. And so when you hear something, like a loud noise to the right or left side, it's going to allow you to turn your head towards that. So that saber-toothed tiger makes a noise that's jumping out, and we hear that, we're going to turn our head towards the noise. So those two centers are very important, and when we study special senses, we'll look at what pathways connect to them to do that. I know that you're excited about that. Just can't wait to get there, right? All right, other nuclei of the midbrain. I'm trying to give y'all things and be a little silly, because if not, this just becomes monotonous and kind of boring to you, of just, I gotta remember this stuff. Well, sometimes you'll remember it if I say something dumb during it. Substantia nigra. Anytime you hear, there's several words that are always linked together, and you'll learn to also. When you say substantia nigra or you say dopamine, you should always be thinking about Parkinson's disease. Is Parkinson's disease the only movement disorder? No. But especially in textbook testing, when you hear substantia nigra, dopamine, substantia nigra is a bunch of darkly pigmented, melanin pigmented areas that release dopamine. And dopamine is largely responsible to help control subconscious movement activities. So when you start to lose the neurons that are part of the substantia nigra, and there are other areas that have dopamine producing neurons, but this is the large one. The substantia nigra, if you lose those neurons, you'll start to see people who heard of Parkinson's, uncontrolled or subconscious tremor, right? They're tremoring. That's why. Part of it. We're still learning about that, but loss of those is associated with Parkinson's disease, meaning that's not the only thing associated with Parkinson's. We're still figuring all that out. Red nuclei are part of my favorite. Axons from the cerebellum and the cerebral cortex synapse with the red nuclei and help to control muscular movements, specifically the large muscles of your shoulder. That's the fun part. I'll come back. Well, those of you who have studied anatomy in more depth have probably gone through the spinal cord many times. And if you're, you get a cross section and it's all color coded, and you have to name each tract and what it does. Again, we're not going to point and see any of the tracts. What I'm going to do is we go through this today and tomorrow. I'm going to teach you how to look at the name of the tract and know exactly where it's going from, where it's going to, and what it's probably doing. Whether you ever can label it or not. Because you're not going to remember how to label it. You're going to remember what the tract does. But we don't need you, and I can start. I'm going to wind up repeating myself so you get this. Because you get into neuro, you start going, oh, what does the rubrospinal tract do? Okay, well, if we know. Now, rubro is a harder one because we've probably never heard of rubrospinal. But I'll show you easier ones later. But rubro probably means red. So in the body, the only place we have red nucleus, and are they red? Not really. All right, but the red nucleus, it appeared that way to somebody, right, is where the rubrospinal tract originates. So they call that the red nucleus. The red nucleus is found in the midbrain. Right? So if you say rubrospinal, what's spinal mean? Spinal cord. Okay, is the midbrain above or below the spinal cord? Right? It's above it. I would just pause and put it back there. So if it's going from the midbrain to the spinal cord, every time they name a tract, it says where it's going from to where it's going to, in that order. So red nucleus to spinal cord means that this is what type of tract? Ascending or descending? Descending. So now we know it's descending. What are all descending tracts? Motor tracts. That's where I'm going with it. If you know that, you can figure out any of them. So what if I said, okay, I have a spinothalamic tract. Is that an ascending or a descending tract? Yeah, spinal cord to the thalamus. So now we know that's a sensory tract. We know exactly where it goes from, where it goes to. Whether we ever can label it, no, until I started teaching it again. That's why I do that, is when I started teaching again and I worked in the spinal cord, I couldn't just label that on any given day of the week. I mean, I could pick out, the pyramids, come on, we can see them. The pyramids, you can see those. I'll get back more to that. So don't get worried about when we start talking about there's all these tracts. That's why in the beginning, going full circle, what did I say about these areas to learn that's most important in each area we go into is the nucleus. What are the nucleuses found in the medulla versus the pons? And just what are they responsible for? What are they controlling? And you'll get the rest when you're studying for it. Because I talk a lot about how they connect and work more than. Now, the fun part of the red nucleus. I'm going to keep saying this until somebody proves me wrong, but I love to people watch. Right? And one of the things you notice as you go through PA school and you learn gait patterns, like heel strike, and those of you, some of you have had experience with that, is you wind up watching people. Not like you're going to say anything to them, but you're like, and their gait pattern is way off. Like, why is that kid playing soccer and running on the fronts of their, they're up on their balls of their feet running? That's actually a neuro problem. But I see kids like that sometimes. But I watch people. You're sitting in the airport or watching, like, wonder if not that I'm going to, like, you got a hip problem. I wonder if he knows what's causing that. Because gait patterns tell you a lot. But what's funny to me, it's not what's funny to me is not always funny to everybody else, is the red nucleus controls crawling of babies, right? Because it controls the large shoulder muscles, but it doesn't control your fine fingers of your hand. But in adults that are up walking around, when we walk, your arms swing, right? You don't even have to think about it. Your arms just swing. But there are lots of people in this world, and probably one in this class, and I don't mean it negatively. You watch for them. Some people walk around, go to, Home Depot. That's not a good one. I was going to say the mall, but nobody goes to the mall anymore. Go to Walmart and watch. You'll see people. I mean, they don't swing their arms and they walk like that. I often say, man, is that a problem with their red nucleus? Or are they doing it on purpose? It doesn't seem odd until I start doing it, right? You gotta let your arms go. Where else do you see that in basic training? When people start working? They're learning to march and they do that with their, like, hey. I don't care if you swing your arms if you're in front of you. Just stay in step. Golly. All right, I need to stop today. I'm having too much fun. Okay, reticular formation. The reticular formation can be thought of as an area. We separate all the time the gray and the white matter. Okay? The reticular formation is a huge mixture, salt and pepper looking area of gray and white matter, which means it contains a lot of tracts and some neuron cell bodies, which goes against, because now we're going to say not all of the neuron cell bodies are found in each nucleus, but there are some scattered throughout, particularly in this area, the reticular formation, and they've mapped this out to kind of see what it does. Right? The reticular formation, once again, it looks like this. Here's where we would picture it. So there's neuron cell bodies and tracts, and it has sensory and ascending fibers, so motor and sensory. And the function is to regulate muscle tone. So all muscles have tone. I told you one motor unit's always kind of contracting. And so that's controlled here. So in muscles, right, you regulate this muscle tone. And it's also what they've mapped out and found as part of the reticular activating system, meaning that they think it helps you maintain consciousness and participate like in waking from sleep. When I came through PA school and we talked about this, they described it differently and said, the reticular activating formation actually knows, it's like a gyroscope area. Like your phone knows whether it's face up or face down. Your body knows whether you're laying down or you're standing up. There's a lot of different receptors that go into that, but they think that this area gets activated to awaken you. But the way they used to describe it is that if you lay on the couch, if you sit on the couch and watch TV, you don't get as tired as if you lay down. You're probably like my wife. I know if she lays down on the couch to watch TV, she got a good 2-3 minutes and she's out. I always say your reticular activating system kicked in, knew you were laying down. Some of that's true. That's why some of y'all are having problems sleeping because you won't take the TV out of your room. Shouldn't have a TV in your. I got a TV in my room. But I don't watch TV in my room. My wife does sometimes. I will not lay down in a bed unless I'm in a hotel room or something and watch TV. It ruins your sleep-wake cycle. You're teaching your body to lay flat. Now when you lay flat and try to go to sleep even without TV, your body thinks it's time to stay up. There are only 2 things you should do in bed. One of them sleep and the other we can't talk about here. The rest of that time, You don't need to be watching TV. If you're having trouble sleeping and you don't know why, throw the TV out of your room and go and focus on the other two. Okay, serve up. Just being honest. All right, we're gonna call it. We're done. I was looking, if I can go to it, you know when I start doing that, I'm thinking about we're out of here. We're running out of time anyway. I think I'm already, well, I'm in y'all's time. It's starting to- Any questions? All right, sorry for all the bantering and joking around.